Hello and good evening. Thank you for joining us on this series of webinar. This is the program called Updates on Glycemic Control Biomarkers in Diabetes, and it's organized by the Emory Diabetes Training Academy. And I would like to thank the Emory Diabetes Training Academy for organizing. My name is Rodolfo Galindo. I'm an associate professor of medicine at Emory University, and also an investigator for the Center for Diabetes and Metabolism Research, and also the medical chair for the Hospital Diabetes Task Force. It is a great pleasure for me to be able to organize and to serve as the director and moderator for this program. The objectives of the program is to provide practitioners and clinicians like you on the role of glycemic control biomarkers in diabetes, particularly on the potential role of glycated albumin in monitoring glycemic control in patients with diabetes. There have been several studies validating the use of glycated albumin, but it was not available until recently that it became available in the United States. So this is just providing education on that need for the US physicians. This will be a series of webinars. As I mentioned before, we will have 6 lectures, and I'm very proud and also thankful for the faculty. We have a great, talented, and international known experts that agreed to participate as faculties. The first lecture will be on April 28 today, and it will be by Dr. Guillermo Umpierrez, and the title will be Current State of Diabetes Management. The second lecture will be on Wednesday, May 12th. The title will be Glycemic Control Markers and Going Beyond Hemoglobin A1C to Guide Diabetes Therapy. And I have a great pleasure to have Dr. Elizabeth Selvin from Hopkins to give that lecture. On May 26th, again, this is a series of webinars every Wednesday evening. On May 26th, we will have a lecture on glycated albumin versus hemoglobin A1C in the evaluation of glycemic control in patients with diabetes. And that will be given by Dr. Vivian Fonseca. On Wednesday, June 9, we will have another lecture, is role of glycated albumin in patients on dialysis. And that will be given by Dr. Barry Friedman. On June 23rd, we will have validation studies of glycated albumin as a marker for glycemic control. And I have the great pleasure to have Dr. Cyrus de Souza. And to finish, on July 7, I will be discussing on glycated albumin as a biomarker of diabetes complication. So the way we have organized the program would be an introduction and then 40 minutes lecture with sessions of questions and answers towards the end. So I encourage participants to pause and ask questions throughout the lecture on the chat, and we will be discussing after. I will serve as the moderator, and then after the lecture, we will have 5 minutes evaluation of the program. So thank you very much, and it's a great pleasure for me to organize these type of educational opportunities, but mostly because your commitment to patient care and to improve the quality of diabetes care. So thank you so much for joining us, and let's just start. Thank you again, and let's start today. So I have a great pleasure to have with me today Dr. Guillermo Umpierrez, who is a professor of medicine and the section chief of the Division of Endocrinology at Grady Memorial Hospital. He also is the president-elect of Science and Medicine for the American Diabetes Association. It is a great pleasure for me, and I thank him for accepting to be a faculty. He will be discussing today the current state of diabetes management in the United States and the world. Welcome, Dr. Umpierrez, and let's just begin. Thank you much.
Well, thank you very much, Dr. Galindo, and thank you for putting together this impressive symposium. Today, I will discuss on the current state of diabetes, of type 2 diabetes management. I will review the 2021 ADA and ACE algorithm for the treatment of type 2 diabetes. But before we get there, I will tell you how we have gone through the year, through the decades, how we had advanced our knowledge and our target for diabetes treatment. And we'll discuss what important factors have applied to reach this algorithm in pharmacotherapy. So let's start in 1990. From 1990 to 2008, our goal was efficacy, meaning lowering hemoglobin A1C. And that was what we wanted to do. And that was the result of 2 large studies. One was the diabetes complication control trial that in the 1990s told us that with increasing hemoglobin A1C, what you see here going from 6, 7, all the way to 11, 12, there's an increase in the relative risk of microvascular complications that include retinopathy, nephropathy, neuropathy, and macroalbuminuria. The highest the hemoglobin A1C, the highest the rate of complications. And the second thing was that these studies told us that intensified glycemic control, meaning retinopathy with insulin therapy, bringing the hemoglobin A1C from about 9 to 7, we were able to reduce the rate of retinopathy, nephropathy, neuropathy, somewhere around 50 to 60%. The second study was the United Kingdom Prospective Diabetes Studies, or UKPDS. And in these studies, took patients with type 2 diabetes, or recently diagnosed, and they intensified glycemic control at that time with a combination of sulfonylureas and human insulin, and a subgroup with metformin. So that they were able to bring the hemoglobin A1C for several years less than 7, and bringing that hemoglobin A1C down for about 1% throughout the study. They were able, looking at the right side of this slide, they were able to reduce the rate of complications, microvascular complications, albuminuria by 30%, myocardial infarction by 60%, and even death. So in that studies also, it was reported that for each reduction of hemoglobin A1C of 1%, going from 10 to 9, 9 to 8, whatever, you were able to reduce death for about 20%, microvascular complication between 30 to 40%, and myocardial infarction by 14%. So we care about efficacy. So in the following year, from 2008 to 2017, there were several large randomized controlled trials, multinational studies that reported that intensified glycemic control resulted in an increased rate of hypoglycemia. And you see, for example, here a VADT at 3,000 studies and the Veteran Administration Hospital in the United States, and a core at US study on over 10,000 patients, and advanced and international, mainly in Australia, New Zealand, and several other countries, that intensive glycemic control is associated with 2 to 3-fold increased rate of hypoglycemia. And these studies show that the rate of hypoglycemia, or the presence of hypoglycemia, was associated with increased rate of death for cardiovascular reasons, on death for any cause, significantly. And here in the bottom, you say that severe hypoglycemia was associated with cardiovascular events about 50 to 60% more. So that came across very strongly, that we have in one hand efficacy, and in the other hand, we have safety. This created what we call individualized algorithm. So the American College of Physicians to the left put this beautiful graph, and it says you have to choose between benefit and risk of harm, meaning hypoglycemia also cost and the burden to the patients. The American Diabetes Association put this beautiful graph showing to the right. And when they told us, listen, you have to select your patients according to, you can be more or less stringent, so more or less aggressive in trying to reduce hemoglobin A1C based on hypoglycemia risk, disease duration. Sure, if you have somebody with 20, 30 years of diabetes, have more complications, so maybe you have to choose not to get a hemoglobin A1C of 6, 6.5, 7. Or somebody with short life expectancy or established cardiovascular complications and support. So nobody can tell you what is the goal for hemoglobin A1C. You have to individualize, and you and your patient have to decide how strong you should be. So when we talk about medications, there are 12 groups of different medicines or formulations with different mechanism of action. 12 of them, so you have to choose. So all the guidelines would say metformin should be the #1. Why? Because work fast, reduce hemoglobin A1C 1 to 2%. It works in a matter of days to weeks, low cost, is not associated with weight gain. Even some people lose a couple pounds. They have a good lipid profiles, And at least in the UKPDS, there was decreased microvascular complications shown in this slide. This is the UKPDS, it's old data and then close to 20 years old. But this patient has been followed throughout, and you see that those patients treated with metformin in the green line to the left was associated with decreased rate of myocardial infarction. And when these patients were followed after the trial was completed all the way for 10 years, those treated with metformin was associated with decreased rate of myocardial infarction. So metformin is the #1 drug, and should continue to be. We have to be aware that about 40% have some mild gastrointestinal side effects, about 4 to 8% are not able to take this medicine. So what we want is to start slow and build up the dose. There is also contraindication in patients who have impaired kidney function less than 30 or GFR less than 30. And caution, don't increase more than 1 gram per day if the GFR is between 30 to 45, because there is the risk of lactic acidosis. In addition, those patients who are actively admitted to the hospital with heart failure or receiving heart failure medication, be careful, because heart failure is one of the reasons why people develop lactic acidosis and shouldn't be taking metformin. Finally, patients undergoing surgery, imaging studies may develop kidney failure, so be aware of that possibility. The second drug used all over the world is sulfonylureas. It works fast, decreases hemoglobin A1C of 1 to 2%. It works in a day or two, it's low cost, and most of them are once daily. And that is why they are so attractive, especially the low cost, because they have been generic now for over 40 years. What is the problem? The problem is the rate of hypoglycemia. In the recent Carolina cardiovascular outcome trial, here in the bottom, you see the rate of glimepiride of hypoglycemia, and about 30 to 40% develop hypoglycemia during the trial. So hypoglycemia is associated with several cardiovascular complications. Some of patients need to be admitted to the hospital. So therefore, the use of sulfonylureas is decreasing significantly during the past few years. And it will not be because of the low cost. Likely, we shouldn't be using it, sulfonylureas, in most of our patients. In addition to hypoglycemia, it produces weight gain. You need to be careful in patients with renal hepatic disease. And there's some questions regarding the long-term cardiovascular safety. TZDs, thiazolidinediones, were commonly used. That's right. Most of us remember that 1 out of 3 patients with diabetes were treated with TZDs 2 decades ago. Because it worked fast, it reduces hemoglobin A1C, similar to metformin therapy. They have no produced hypoglycemia, now they are generic. And it's once daily, and it has some cardiovascular protection. But unfortunately for the TZDs, there's tremendous disadvantage. Subjects increase body weight by about 2 to 4 kilos. That is 2 or 3 dress sizes for women. They don't like it. The slow onset of action, you have to wait up to 2 or 3 months to see the maximal effects, produce fluid retention, edema, worsening heart failure, cannot be used in patients with heart failures grade 3 or 4. And to me, something very, very important is that have been associated with decreased rate of bone fractures, especially in postmenopausal female. So the utilization of TZDs has come down from about 30% to less than 5%, despite the fact that they are generic. The next group of medications are the DPP-4 inhibitors that have been available now for almost 20 years. Next year, one of them is become generic, the sitagliptin. They are widely used because they're weight neutral. They're not very potent, but they're not associated with side effects or hypoglycemia. So the side effects is minimal. The main problem is going to be cost. But unfortunately, they're not very potent. And we'll see here is that all of this, the DPP-4 availables in the market, they get a reduction about 0.5, 0.6, 0.8% maximum. So if you have somebody with hemoglobin A1C of 8 or 9, they're never going to reach goals. The other thing is they are cardiovascular safe. That's good. But now we have medication that reduce cardiovascular risk. So the DPP-4, unfortunately, have cardiovascular neutral. So the utilization of DPP-4, at least in the United States, has significantly reduced, although it's the third drug most commonly used in our patients with type 2 diabetes. Significant amount of information has come out for the GLP-1 in patients with type 2 diabetes. And as you know, we have short-acting and long-acting. We have daily and weekly medications. Here you have the potency. They reduce hemoglobin A1C between 0.8 to 1.5%. So much more than what you see with the use of DPP-4. And all of them work, and some of them a little more than others, that you would expect to have somewhere around 1 to 1.5% reduction of hemoglobin A1C. The other thing is that in doses that are used for diabetes, they produce weight loss. And you should expect to have somewhere around 1 to 4 kilograms of weight loss when you use these medicines in type 2 diabetes. And of course, 80% of patients with diabetes are overweight or obese. So losing 2 to 4 kilos is very welcome. Perhaps the most important impact that the GLP-1 have had during the last few years is the results of cardiovascular outcome trials that have shown that the GLP-1 are associated with reduced major cardiovascular events, or what we call MACE. And here you have several studies: liraglutide in the LEADER trial, semaglutide, albiglutide. All of them have shown that they reduce MACE that involve cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. So if you have a patient that the #1 cause of death in patients with type 2 diabetes is cardiovascular disease, these agents have been shown to reduce the rate of cardiovascular death, MI, stroke, somewhere around 15 to 20%. In more recent trials, the SUSTAIN 6 cardiovascular outcome also shows a significant reduction of 25% of MACE, and also reduce the rate of strokes and myocardial infarction. So that's great. That's right, the #1 cause. The other thing of death, the other thing is that all of the GLP-1, or most of the GLP-1, have shown to be renal protection. And you are seeing here the result of the liraglutide trial versus placebo. It reduced a composite of macroalbuminuria, doubling of serum creatinine, and renal death, but about 20%. And the new onset of persistent macroalbuminuria was reduced by 26%. So these agents are able to reduce the rate of progression of renal disease. In a recent study comparing Dulaglutide, a GLP-1 that is given once weekly, in this trial was compared to Glargine. The effects on glucose was very similar. So GLP-1 produces a reduction of hemoglobin A1C very similar in most patients compared to basal insulin. But here to the left is the change on renal function. While Dulaglutide was able to preserve renal function, in red is the higher dose, in blue the lower dose, versus Glargine and basal insulin did not prevent the appearance or reduction of renal dysfunction. And to the right is microalbuminuria. So that has left the effects on the cardiovascular and the effects on the renal component that the American Diabetes Association have recommended that if an injectable therapy is needed, so you have a patient with 2 or 3 oral agents, and you say, well, I'm going to use an injectable, they could be insulin or GLP-1. GLP-1 should be considered ahead of insulin in most patients. And if you do not achieve goal, you should combine the two of them. So we go from metformin to GLP-1 to insulin therapy, because GLP-1 has cardiovascular and renal protection and don't produce weight gain that we usually see when we add insulin therapy. Let's move to, before that, there you have to be aware of the disadvantages. That's right. About 30% or 40% of patients have some nausea or vomiting. So you have to start at the lower dose and build up your dose to be able to be tolerated. Cannot be used in combination with DPP-4. There is a risk of pancreatitis slightly, but it's there, and should not be used in patients with medullary carcinoma or MEN. The main disadvantage is the high cost, which is significant in most countries. The final group is the SGLT2s for patients with type 2 diabetes. And of course, in the United States, we have 4 of them. In other countries, there are many more, like in Japan, I'm aware there are 7 different SGLT2s in the market. So you all know how it works. It blocks the SGLT2s receptor, so you produce glycosuria. And if you produce glycosuria, you're going to have weight loss, and you're going to lose calories because you're just spilling sugar in the urine. So it works fast. It reduces hemoglobin A1C by about 0.8 to 1.2%. It is insulin independent, so it is not associated with hypoglycemia by using by itself. And of course, as I mentioned before, it has produced some weight loss. And more importantly, similar to the GLP-1, these type of agents have been shown to have cardiovascular and renal protection. Here you have the effects of the 3 most commonly used GLP-1, and you see a reduction of 0.6, 0.7 to about 1.1%. So they're not as potent as GLP-1, but they're significant, about 1% reduction. They produce weight loss in about 1 to 3 kilograms. Again, if 80% of my patients with type 2 diabetes are overweight or obese, losing 2 or 3 or 4 kilos is very welcome. But more importantly, the SGLT2 inhibitor has been shown to reduce major cardiovascular events. And you have several of them, EMPA, CANA, DAPA, all of them have been shown to be beneficial, have cardiovascular benefit. Here you have the rate of myocardial infarction, cardiovascular death, and strokes. In the EMPA-REG study with EMPA, CANA, and DAPA, all of them show a good report. But more importantly, what we have learned is that they reduce the rate of heart failure. A patient that is admitted with heart failure, with or without diabetes, 30% of them are readmitted within 3 months. And about 50% will be readmitted or they're dead after a year or 2. So reducing readmission for heart failure is cost-effective and life-saving. And here you have the EMPA-REG, CANVAS, and DAPA. They all show the reduction in readmission for heart failure, somewhere around 30 to 40%. Very highly effective medicines. And in patients who have low ejection fraction, so an ejection fraction less than 40%, dapagliflozin have been shown not only to reduce readmission, but reduce death. This is why the FDA have now approved the use of DAPA for patients who have low ejection fraction, even if they don't have diabetes. In addition to the cardiovascular benefit, they have a renal protection mechanism. And all of them, EMPA, CANA, and DAPA, and NER2, have been shown to have significant protection. Here you have the effect with the EMPA-REG, with the worsening nephropathy or new onset or worsening nephropathy reduced by almost 40%. And the new onset macroalbuminuria, it was reduced by 38%. So, and this is independent of the use of ACE inhibitors or ARBs. So you have patients, and we all have patients that already are on ACE inhibitors and they still have proteinuria. These agents, in addition to the effects of ACE, they have a renal protection. And in the latest trial that is called Credence, they took even patients with significant albuminuria with urinary albumin creatinine ratio between 300 and 5,000. The use of these agents with a GFR between 30 to 90 reduced significantly the doubling of serum creatinine, renal or cardiovascular death. This is why now we have gone from efficacy to safety, and now we have cardiovascular and renal protection. So we move in the last few years, considering high-risk patients the use of GLP-1 and SGLT2s. How this trial has affected our guidelines? Well, in the year 2018, I was a member of standard of care, and we said monotherapy with metformin, 3 months later, you're not at goal. We used to say go to each one of these medicines shown in the bottom, but now we added one more step before we reach there. And we asked the patient, do you have cardiovascular disease? Or you ask the patient, have cardiovascular disease, yes or no? If the answer is yes, the current guidelines would suggest that you should use an SGLT2s or a GLP-1 receptor agonist. And the answer is no, you still consider GLP-1 or SGLT2s, but you can also consider other medicines that are on the market. That was 2018. Last year, we modified a little more, and we said, well, if the patient has atherosclerotic cardiovascular disease, so ischemic cardiovascular event, stroke, you can use GLP-1 or you can do SGLT2s independent. But if the patient has heart failure, you should use SGLT2s. Why? Because it reduces readmission for heart failure, and GLP-1 does not reduce risk of heart failure. It reduces cardiovascular events, but not readmission for heart failure. And now this year, we say, those recommendations for heart are there, but what happens if the patient has nephropathy? So there's no question that ACE inhibitors help, but half of the patient continues to have proteinuria, and you should consider to use GLP-1 and SGLT2s in this group of patients when they have proteinuria or the GFR is less than 60. Remember that nephropathy is one of the highest risk factors for cardiovascular events. And if the patient have albuminuria this year, we says SGLT2 have a little edge over GLP-1. So we try to use GLP-1 when the patient has proteinuria. So everybody should be there. But don't forget, we have glycemic targets, that's right. And so far, during the last 30 years or more, we have gone to targets with the hemoglobin A1C. These are the ADA would recommend reaching a hemoglobin A1C less than 7%. If you can do it with no hypoglycemia, ACE is more strict and have less than 6.5, and ACE say, well, why do you have to stop at 7? If you're using medications that are not associated with hypoglycemia, bring the hemoglobin A1C as low as possible. Again, that you have to look for potential side effects shown in the bottom of this slide. The American College of Physicians have more relaxed goals, 7 to 8% for most patients. But if the patient have long life expectancy, is healthy, why not bring the hemoglobin A1C less than 7 or lower than 7 or 6.5%? So hemoglobin A1C have a lot of deficiencies. So first, it just give you an average for the last 3 months or 4 months, that's right. But now we have alternatives. We have glycated albumin, fructosamine. And what you see in here is that glycated albumin, it gives you a rapid assessment of how the patient is responding to therapy. I'm putting here in the bottom is the time where the 50% of the reduction of glycated albumin is seen in 17 days, in less than a month. It gives you a 75%. So if you start a patient on insulin, you really have to wait for 2 or 3 or 4 months to see the maximal effects on hemoglobin A1C. If you use glycated albumin and fructosamine, fructosamine measures glycosylation of all proteins, and of course, glycated albumin, glycosylation of albumin molecule. You see the most effects within a month. And within 2 months, you see the maximal effects 100%. During these lectures, Dr. Galindo has invited several national and international professors who have long experience on the use of glycosylated albumin and fructosamine that will be lecturing in the future. But I think this is something new that has been approved by the FDA. And in patients who has renal disease or end-stage kidney disease with dialysis, where you know that these patients, hemoglobin A1C is useless. I mean, how many patients have hemoglobin A1C of 4 and glucose of 200 or 300, and that's the reason why they ended up in dialysis. This group of glycosylated albumin provides a major impact on utilization in this group of people. So let me summarize what I have learned. First, there are multiple medicines. They all work, but they all try to fail. That's right. That's the reason they all work. They produce hemoglobin A1C, some of them more than the others, but more importantly, they fail. And if you use metformin, sulfonylureas, about half of the people fail. So don't expect much more, because the beta cells of the pancreas decrease the insulin secretion with longer duration, and you have to combine this medicine. What we're trying to do with standard of care is motivate our providers to consider efficacy, bring that hemoglobin A1C, but do it in the safe way. Try to avoid medicines associated with hypoglycemia if you can. And not only now we go from efficacy of safety, but I hope that I have convinced and provided the evidence that now GLP-1 and SGLT2s have shown to have cardiovascular and renal protection in our patients with diabetes. So I want to say thank you to Dr. Galindo and the organizers for inviting me to present these lectures that I think I try to illustrate how we have evolved in the treatment of type 2 diabetes. Now we have medicines. Now we need to assess or change the way how we're going to assess glycemic control. And throughout the years, we used to do glucose testing, first urine testing, then blood test, now hemoglobin A1C. Now you have other options like glycated albumin, fructosamine, and glycated albumin provides a more shorter assessment of glycemic control compared to hemoglobin A1C. Thank you, Galindo, and best of luck in your symposium.